My name's Aaron Sahai. I'm a consultant urologist at Guy's Hospital.
And my name's Sophia Cashman. I'm a registrar in East of England.
So we have a very exciting lineup for you today. It's a very interesting topic area, very challenging patients in this group who have been exposed to radiation. My colleague, Mr. Majid Shabir, is a consultant andrologist at Guy's, will be talking to us about the sexual function aspects of radiation damage. Nikesh Thurachelvam from Addenbrooke's in Cambridge, who we all know well within our section, is going to be talking about urinary incontinence. Professor Fisch, who knows no introduction, internationally renowned reconstructionist and urologist, will tackle fistula. And then we have Tasha Malinowski, who's come from the prostate cancer charity, who we're very pleased to see today. She's going to give us an overview of the projects which has been run by the charity as part of their Health Social Care Professionals program, and her talk will be based around some case studies and some videos, I understand. Well, hopefully the speakers will keep to time. They've all got 20 minutes each. If they do finish early, we'll ask questions at the end of the talks, but if they're running to time and it's 20 minutes, then we'll just have a Q&A at the end of the session. So we'll kick off, I think, with my colleague, Mr. Shabir.
Thank you very much. So, cancer survivorship is becoming an increasingly important area. The incidence of cancer is increasing, treatments are becoming more effective, and as a consequence, patients are living longer and living beyond their cancer diagnosis and beyond the treatment effects that we're going to see. So survivorship becomes important, not just looking at the quantity of life, but also the quality of life of patients after their diagnosis and treatment. When I was given this topic title initially, I had a look at it. You thought, well, this is mostly going to be about prostate cancer, because prostate cancer is the most common thing that we come across as urologists. But looking at radiotherapy to the pelvic region, there's a whole host of other cancers that we come across. Among the male-specific cancers, testicular cancer and penile cancer may also involve radiotherapy. And there are the female-specific cancers and also the cancers which can affect both men and women as well. Radiotherapy exerts its mechanisms of effect and injury via the same approach. The DNA damage and the changes to the vasculature and inflammation that arise as a consequence can lead to damage to the surrounding tissues that can lead to the consequences that we come across. And it's easy to see that when you look at the vascular damage, neuronal injury, endothelial changes, how this may lead to things like erectile dysfunction, which again is the thing that was probably the most prevalent thing in this talk. But pelvic radiotherapy doesn't just lead to erectile dysfunction, it leads to other consequences with sexual dysfunction and also with fertility. And all of these can be considered sexual consequences of having the radiotherapy treatment. When considering the effect on the individual, it's all about looking at the different aspects of that patient's treatment and pathway. Pre-treatment factors such as the patient's age, what their baseline sexual function is like, what their baseline fertility is like. What about their comorbidities? If they have diabetes or cardiovascular disease, they may be more prone to developing problems with sexual dysfunction afterwards. What about treatment factors? It depends on the type of cancer that they have to start off with. What about the impact of any other treatment they're going to have? If they have surgery, that in itself could impact their sexual function prior to them having any radiotherapy afterwards. And are they going to have any combination treatment? If they have androgen deprivation therapy as part of their pelvic radiotherapy, it'll have more of an impact on their sexual function overall. What about factors related to the radiotherapy itself? Well, the extent of the treatment field will determine the extent of the side effects that you'll come across, the total dose that you're given, the fractionation schedule that you have, and whether this is external beam versus brachytherapy as well can also make a difference in your outcomes. And again, if this is adjuvant therapy after surgery as opposed to therapy as a primary treatment, you may see differentiating effects. When treating the pelvic region, the gonads are particularly susceptible to damage from radiotherapy, and the hormonal changes that come here can also have a severe impact on sexual dysfunction and fertility afterwards. And not forgetting the psychological impact of the original diagnosis itself and its treatment on the sexual function in patients in the longer term. So the mainstay of the talk you would think would be about radiotherapy causing sexual dysfunction and mostly about erectile dysfunction. But when looking at men, it's not just erectile dysfunction. They do get problems with their ejaculation, they get problems with changes in their libido, and they get changes to the shape and size of their penis as well. And it's important that when we're counselling patients, we don't just focus on erectile dysfunction. If you look at the journals, that's what they mostly focus on, but it goes way beyond that. And it's important that patients have a realistic understanding about what they're going to experience and achieve or not be able to achieve afterwards. And as we said before, all of these are heightened if you have androgen deprivation therapy at the same time. It has a greater impact on the libido, a greater impact on the fertility, and also on the orgasm sensitivities as well. But like we said, it's not just about sexual dysfunction, it's also about the infertility that can arise as a consequence. And this is often a bigger problem than you expect. Even in prostate cancer patients, we'll often have patients in their 60s wanting to preserve their fertility prior to any treatment. And the effect of radiotherapy is twofold, a direct gonadotrophic effect or the scatter effect, which may be more recoverable if it's just from pelvic radiotherapy having its distant effect. In women, again, we see a similar type of pattern, sexual dysfunction and fertility issues. And we're going to go into each of these in a bit more detail throughout the rest of the talk. Again, the extent of the radiotherapy field that patients have will determine how much of a change they have afterwards. The biggest change that women get in sexual function afterwards is with vaginal dryness, subsequent delayed fibrosis and atrophy. And according to how much of a radiotherapy field you have will determine how much of an effect you have, with vulval cancer, rectal cancer and anal cancer being far more susceptible to damage because of the field of treatment. But is it important? Well, yes, it is. Sexual dysfunction itself has a negative impact on the quality of life. It affects patients' ability to form relationships, it can lead to marital discord, and it can affect their self-confidence. Fertility as well, by itself, can cause a lot of stress within patients and increased levels of depression. If you then superimpose both of these on top of a cancer diagnosis, it can lead to a significant amount of stress for that patient and their partner in their survivorship after their cancer diagnosis. So when should we tackle issues with sexual function and fertility? Well, the time to do it is right at the very start, because you get your best outcomes with fertility preservation right from the very start before any therapy. And there's also an increasing concept of what's called prehabilitation for cancers, rather than waiting to respond in a more reactive approach. But when you see that patient in the clinic, sexual function and fertility is probably the furthest thing from their mind. They're more worried about the cancer, the treatment coming out the other end. But we have to think about how successful we're going to be with that treatment and take those decisions for them and lead them through that pathway of what to expect afterwards, where they may not be so concerned. The question is, who's the right person to do that? Should that be done by the oncologist who's seeing the patient in the room, or should it be done by somebody else? Should there be a separate session set aside to discuss functional issues afterwards? And I think maybe the increasing trend should be that we should think about separate sessions to discuss life after cancer and not include it at the same time as treating the cancer itself. So the concept of prehabilitation is all about preparing that patient for what is to come and seeing if you can set into motion certain plans that are going to avoid the consequences of your treatment. The idea is to do this before you start any treatment. You assess their baseline function, you think about factors that are going to make their condition particularly worse, and you prepare them both psychologically and physically for the expected changes, give them ideas, realistic timelines of how things are going to occur, and put in place management strategies that are going to avoid that in the longer term. And if you do this, we can reduce the incidence of the episodes, but also reduce the patient's regret with what they end up having. And in fact, especially with the example of prostate cancer, patients will often choose what type of therapy they're going to have according to what functional deficit they're going to have afterwards. Patients may choose to have brachytherapy over external beam radiotherapy or over surgery because of its reduced effect on erectile function. So having that knowledge and information beforehand can be vital. So how can this be achieved? Now, this is not going to be readable, but this is just an example of a sheet that we use. This is a one-page piece of paper that outlines the sexual dysfunction that you're going to get as part of your treatment. And we produce one that's for radiotherapy, we produce one that's for surgery, and for the different treatment modalities. And this one's specific to prostate cancer. And the idea is this is written in simple, plain English. You give it to the patient. So if you don't manage to get them to remember all the aspects that you've discussed during the session, they can walk away and read about it, and they're aware about the impact. And if you give them one for each of the different treatments that you're proposing, it gives them enough time to sit at home and contemplate what's going to be the outcome of that intervention in the longer term. And this can be quite a helpful way of starting your prehabilitation process. So focusing slightly more on the actual individual sexual consequences and how we can manage them. Erectile dysfunction, probably the most important, probably the most prevalent, especially among the prostate cancer patients. It's again dependent on your pre-treatment function and your comorbidities. You have less of a problem with erectile function with radiotherapy than you do with radical prostatectomy, and probably slightly less with brachytherapy than you do with external beam radiotherapy. The effects are more significant if they have concurrent androgen deprivation therapy, and it remains slightly unclear, although you would logically think that patients who have radiotherapy as an adjuvant immediately after they've had cancer surgery would have a worse outcome. The evidence in the literature is not quite clear, but it's probably due to the way in which the studies have been conducted as opposed to anything else. The difference about erectile dysfunction after radiotherapy is it is inherently different to the erectile dysfunction after surgery. After surgery, it's more neurogenic erectile dysfunction due to neuropraxia or cutting of the nerves. In radiotherapy, it's more vasculogenic, and as a consequence, they probably respond better to PD5 inhibitors in that early phase. The difference again here is that after surgery, you develop erectile dysfunction immediately, but in radiotherapy, you may not develop that erectile dysfunction for up to 2 years after the treatment because you have this delayed accumulative effect of the therapy. Once you get to 2 years, what you have is probably going to be what you'll have in the longer term as well. So PD5 inhibitors still remain the first-line treatment for patients with erectile dysfunction after radiotherapy, and it's probably more effective, as I said, in this setting than it is immediately after radical prostatectomy. But there's also the question about penile rehabilitation, which has been hotly discussed within the post-surgical groups. But what about in the post-radiotherapy group? Well, there have been 2 studies which have been published in 2014 looking at this, Zelefesky and Pizanski, both in 2014. The first study, Zelefesky, looked at giving daily Viagra 50 milligrams versus placebo in a randomized controlled trial. They started it from 3 days prior to the radiotherapy and gave it up to 6 months after treatment, and they saw what the effects and the difference was. If you have a look at the graph, pointer doesn't work, but if you have a look at the graph, the differences were evident while you were on the treatment, but even once you stopped the treatment here at 6 months, the arrow is not showing, you had continued benefits from having the radiotherapy and Viagra for a further year after the therapy had stopped. But this wasn't repeated in other studies. So the Pizanski study, which used once-daily Cialis as a form of rehabilitation, showed benefit while you were taking the medication, but as soon as you stopped, you were back to the same as before. So the concept of giving it for rehabilitation is unclear in radiotherapy. What do we do as alternative therapies? Well, along with erectile dysfunction, patients can get changes in the penile shape and length and size after they've had treatments for prostate cancer. The development of Peyronie's disease after radical prostatectomy is probably higher than people really appreciate. But after radiotherapy, there's no clear evidence about how much or how prevalent the condition can be. One of the things that we know is that if you have patients who have radical prostatectomy, early use of things like a vacuum constrictive device can be good at maintaining the stretchability of the penis and trying to limit the penile shape changes and length change that you may see. But how and when you use this in a post-radiotherapy setting is a bit unclear at present. The use of things like alprostadil remains the same and as effective as it would have been in a surgical setting, and penile implants still remain a viable option in patients where everything else has failed. Again, the difference here would be the timing of the penile implant. If someone's had surgery for prostate cancer and there is a chance that there is a nerve spare approach, you would like to give them as much time to re-establish normal erections from their neuropraxia, anything up to 2 years before you consider putting an implant in. With radiotherapy, they start off better and they get worse as time goes by. So actually they get to their worst effect between 1 to 2 years. So if they're not responding to treatment at that stage, you can consider an implant at an earlier stage. Now again, if you look at the literature, there isn't much about the other aspects of sexual dysfunction that you come across. So developing ejaculatory changes, there is very little evidence for why this occurs, or very little evidence of how best to manage this. The thoughts are that this is all due to problems at the ejaculatory duct level, either obstruction physically with the seed or with fibrosis as a consequence of the radiotherapy, and that can't be undone. Some patients just develop inflammation from the radiotherapy itself and behave almost like a chronic prostatitis. There is some evidence to say that there's a correlation between the number of needles that are inserted at the time of brachytherapy and the amount of post-operative orgasmic pain that they develop. And about 1 in 4 patients can develop a decrease in their ejaculation after they've had brachytherapy, and that can obviously impact on their fertility as well later. These patients are generally managed along the same pathways as the chronic pelvic pain syndrome patients, using things like alpha blockers. There is very limited evidence about using once-daily Cialis in patients with chronic pelvic pain syndrome, and certainly we've had some success locally with doing this. The exact mechanism is unclear, but it may be related to the anti-inflammatory action as well as some of the smooth muscle relaxation in the area. But other penile shape changes and length changes that you may see can be related to the delayed effects of therapy, things like genital lymphedema. This doesn't occur in all patients, and you wouldn't typically see this after the prostate cancer therapy treatments, but this is talking about patients who've had bladder cancer, lymph node dissections, and subsequent radiotherapy, or more prevalently in the penile cancer patients. Developing this type of change can be quite significantly stressful for patients and affect their function as well. But it can be managed with an MDT approach with dermatologists, primarily using things like lymphatic massage, support garments, preventing secondary infections, and only using surgical debridement in the longer term, but you can do reconstructions with skin grafts to take away the edematous tissue. Concentrating more on the female patients now, the most prevalent problem that they come across is early treatment-related menopause. Now, according to the patient's characteristics, the simplest way to manage this will be with HRT in combination with a gynecologist or GP, but it has to be avoided if the patient has estrogen receptor disease to start off with, such as breast cancer or endometrial tumours. But probably the biggest problem, and one of the hardest things to look after as well, is patients who develop vaginal issues as a consequence of having radiotherapy. In the simplest form, it's just simple vaginal dryness. This can be managed with a variety of different creams, daily preparations such as the Replens or Hylofem. These are non-hormonally based, just moisturizers, but they can be used daily. Some patients don't like to use daily creams, and instead they can just use creams with intercourse instead. But if they don't have a condition which restricts them from having topical estrogens, they may fare better by using this approach. Getting vaginal stenosis after you've had radiotherapy, especially in those patients who've had things like vulval cancer, anal cancer, or rectal cancer, can be a big deal, especially in the younger patients. The way to manage this is proactively. Give the patients an idea of what they're going to get after the condition, manage it by early vaginal dilatation using vaginal dilators, and patients are taught how to do this prior to their radiotherapy. They start this about 2 to 8 weeks after the radiotherapy ends. They put the dilator in increasing sizes to make it comfortable, 5 to 10 minutes, about 3 times a week for the first 6 months, and thereby decreasing to about once a week afterwards for the first year. But these patients have to be carefully followed up just to see how compliant they are, because if they're not doing it regularly, they can get into a worse situation. And so generally they should be seen every 3 months for the first year, and then 6 monthly after that. And if it comes to 2 years and they haven't had a good response by this approach, that's the stage at which you start thinking about doing some form of vaginal reconstruction to help overcome their problems, if it's appropriate. It's easy to focus on the physical side and totally forget about the psychological impact of sexual dysfunction on patients. And papers have shown that it's not just focusing on the physical side that you need to do, but by focusing on the psychological aspects, you can improve your outcomes in post-radiotherapy erectile dysfunction, the dyspareunia that women get, and also orgasmic and ejaculatory difficulties in men as well. So focusing on the physical and the non-physical is always important in your treatment effects. Focusing now onto the fertility aspects, the sexual consequences. In men, you can get 2 different types of damage to the testicle from radiotherapy, a direct gonadotrophic effect and a scatter effect from pelvic radiotherapy, which is more recoverable. If you look at the doses that you have to give to the testicle to produce damage, an irreversible level of damage, it's much lower than you think. Just 5 Gray directly to the testicle will cause almost long-term azoospermia. Fractionation of the dose actually creates more of a problem. If you give a fractionated dose at 2.5 Gray, it causes more damage. And if you look at the doses that we give to patients for testicular cancer, for ITGCN at 16 to 18 Gray, that will produce permanent azoospermia in over 95% of patients. How do you manage this? Well, proactively beforehand. Before you give the radiotherapy to the gonad, you preserve the semen. It's the cheapest, most effective, easiest thing to do. And you can do that in anyone who's sexually mature enough to be able to provide a sample with ease. If they can't, you can always do a surgical sperm retrieval prior to any radiotherapy. What about the scatter effect? And this is again looking at testicular cancer patients who have radiotherapy to the pelvic lymph node area. Now, usually this is incorporated with a shielding of the gonad region, so you have less of an effect in that area, but still you can have an impairment of your fertility. So if you look at the pre-treatment dose levels and how things change over time, you have an initial fall at 3 months, which then starts to rise back up again and usually gets back to your pre-treatment levels by 24 months. But not in everybody. Only about 80% of people will get back to where they were to start off with, so be proactive, don't be reactive. Because of the damage that you can get to the DNA with direct or indirect radiotherapy, it's important that you may advise patients to use alternative contraception for the first 6 months at least, but anything up to 2 years after they've had radiotherapy. In women, they also have the same gonadotrophic effect with direct radiotherapy. It's a little harder to shield the gonads in this field though. And again, low doses, just fractionated doses of about 2 to 4 Gray are enough to cause damage to about 50% of the follicles in a permanent fashion. Interestingly, if you give radiotherapy to someone who's prepubertal, their gonads have a better functional recovery afterwards. But again, the idea is to be proactive, preserve that fertility before it gets affected. And how can this be done? Well, oocyte cryopreservation is the best thing to do, but you can only really do this if the patient is sexually mature enough, if they're well enough to undergo stimulation with drugs to increase the ovulation prior to any surgical extraction, and you can delay their radiotherapy by at least 2 weeks. If that's not possible, if they're prepubertal, then it's all about taking ovarian tissue and cryopreserving that to be used for later fertility. But that's being done only in specialist centres and in a research setting. Ovarian transposition has been considered, so that's raising the ovaries out of the pelvic field so they don't get affected by the radiotherapy. And that again is being done in very specialised centres, but is an option for younger patients. And if all else fails, if they've developed complete ovarian failure, then you can still go back and use donor eggs as an alternative or think about adoption. Endometrial damage tends to have need more radiotherapy to cause that level of impairment. And again, here, prepubertal uterus is more susceptible to the damage than postpubertal. It can lead to a reduction in the uterine volume, and there is a limited capacity for repair in this setting, but you can use things like estradiol to try to regenerate some of that endometrium. But despite doing this, such patients are always going to be at a higher risk of spontaneous miscarriage and preterm birth afterwards, and it may be an option to consider adoption or surrogacy in the future. So in summary, there is a growing need to manage the consequences of cancer and its treatment. Impairment of sexual function and fertility are common after pelvic radiotherapy and can have a marked impact on the patient's quality of life after, when they're already having to deal with their cancer in the first place. The concept of prehabilitation is probably the right way to go now. Fertility preservation should be done at the outset, and one should avoid the correct approach to avoid regret after they've had their therapy and treatment. Thank you very much.
Thank you very much for that really comprehensive review. I think in the interest of keeping to time, if we do questions at the end, is that okay? Brilliant. Thank you. So next up, I'd like to welcome Mr. Thirchelvan to talk to us on urinary incontinence.
Good morning, everyone. I'm going to be talking about how radiotherapy can cause or promote or worsen incontinence in our cancer patients. Now, patients get these problems because they may have direct radiotherapy to the prostate or the bladder or the prostate bed following radical prostatectomy, or it may be indirect because of radiotherapy to adjoining organs such as the cervix, the uterus, the colon. And patients can develop symptoms straight away, or it could be late onset toxicity over time. We briefly heard this already, that it's probably a hypoxic change and inflammation that leads to fibrosis and structural change to the lower urinary tract, and then subsequent functional change. And this is well borne out in a number of studies that have looked at this area. And also physiologically, people have done muscle strip work, looked at EMG, manometry. I've also looked at quite at a cellular level, looking at specific proteins to see what is the role and what causes these hypoxic changes, and whether there are any new avenues to try and treat this problem. Now, patients then develop symptoms such as dysuria, they get storage, or LUTs or incontinence, voiding LUTs, hematuria, and then some of them fistula, which you'll hear about later. Some of you may notice that's my finger there in that lady's vagina, and that's... That's my finger there in that lady's vagina. She's got very bad bladder, leakage, incontinence. You can get bad bladders and reflux and very hemorrhagic changes. And you can imagine this is quite problematic to patients. The difficulty in looking in this area is that we're used to treating and looking at patients using IPSS and their symptoms. Oncologists use a very different system. They refer to toxicity. So they look at epithelial changes, telangiectasia, but obviously they're not the ones looking in the bladder, and then ongoing symptoms in terms of bladder size. So it's very difficult to look at papers over time in terms of what's going on, because we're much more used to looking at symptoms. What radiation oncologists have tried to do over time is try and get more and more focused in their ability to deliver radiotherapy, moving from external beam radiotherapy to the more targeted, conformal, trying to hit the organ in the organ shape to try and get more specific radiotherapy to the organ that they're interested in. you get quite a variation in prevalence in exactly what's going on in terms of the rates of incontinence or lower urinary tract symptoms. It appears that radiation certainly does make post-prostatectomy incontinence worse, and some of those symptoms can be progressive and still persist even at 5 years. I published a review in BJU last year that showed varying rates of incontinence following radiotherapy, and there is quite a range there from 17 to 85%. Even quite high-risk prostate cancer, this paper nicely showed over 3 years the degree of urinary incontinence that was persistent. Around a quarter of patients had urinary incontinence. It's unclear whether adjuvant hormones given following radiotherapy affects urinary incontinence prevalence or not. The jury's out on that one. In terms of radiation cystitis, again, there's a nice review there that looked at various different cancers, various different definitions, and various different modes and modality of delivering radiotherapy, and quite a range, but at least a quarter of patients will probably get radiation cystitis and symptoms associated with that. It affects more men, and that's probably because of the radiotherapy for prostate cancer. In terms of colorectal cancer, urinary toxicity, one paper said it was quite mild, 50% said there was no toxicity at all, but around 12 patients, 1 in 10 patients had grade 2 low urinary tract toxicity. Another paper said, in fact, following radiotherapy for colorectal cancer, there was stress urinary incontinence or urge incontinence in almost 50% of the patients. This kind of shows the prevalence following gynecological cancer, and again, incontinence rates are quite high. We're looking down here, urge incontinence, if you've had radiotherapy compared to controls, quite high rates. So does the type of radiotherapy matters? Well, it seems to. Kazani published a paper looking at, again, toxicity, grade 3 toxicity, and showed that hyperfractionated radiotherapy caused worsening low urinary tract symptoms compared to conventional radiotherapy. Another paper looked at brachytherapy and showed that brachytherapy caused worse low urinary tract symptoms than conventional IMRT or stereotatic body radiotherapy. And the bottom paper there by De Boer et al. Showed that for 10 years following external beam radiotherapy compared to vaginal brachytherapy, urge incontinence was reported in 40% of patients with external beam radiotherapy compared to a quarter of patients following vaginal brachytherapy. So the type of radiotherapy certainly does matter. And this is another paper showing the reduction in low urinary tract symptoms. In fact, things got better over time following a relatively new technique for radiotherapy for prostate cancer. And that may be related over time to reduction in prostate cancer prostate size volume. There are some papers looking at what the dose does to the low urinary tract symptoms. It appears that around 70 to 80 gray is the kind of the mark where you start to get significant toxicity. Yahal published a paper that looked and showed that if you have 50% of your doses over 70 gray, that almost 1 in 2 will have significant low urinary tract symptoms. And another paper showed that it was up to 80 gray. In terms of brachytherapy, again, using a high volume, or if it's close to the back of the neck, you're more likely to get troublesome low urinary tract symptoms. Looking at the other cancers, they seem to have slightly lower dosage causing significant low urinary tract symptoms. Endometrial cancer or cervical cancer, it was thought around 40 gray would cause significant urinary incontinence or urgency. That was by Pisani et al. Another paper looking at chemoradiation and brachytherapy for cervical cancer showed at least at 3 years toxicity was 24%. So again, quite high rates, but not as high as the others. Colorectal cancer, it looks around 35 gray. So these organs seem to have or need lower dosage or lower gray to cause significant low urinary tract symptoms compared to what we deliver for the urinary tract. In terms of timing of radiotherapy, this paper quite nicely looked at two different groups in terms of whether they had early radiotherapy or late radiotherapy following prostate cancer treatment. And they kind of showed very similar figures, so no difference in terms of who got radiotherapy early or late in terms of symptoms or leakage. So I won't go into focused treatment of low urinary tract and incontinence because hopefully you're aware of all the guidelines we have, and we basically focus on conservative measures, medical management, and then surgical management. So I really want to look at what effects radiotherapy has on this management of urinary incontinence, and I'll also briefly touch on radiation cystitis. So in terms of conservative measures, pelvic floor muscle training is commonly used and works well for stress urinary incontinence, and one paper by Yang et al. Showed in fact that pelvic floor muscle training had a poorer response if they'd had radiotherapy, but it did decrease incontinence and sexual dysfunction and improve quality of life compared to not giving pelvic floor training. In terms of use of alpha blockers following prostate cancer treatment, again, they had a poor response, and that's quite an old paper in 1999. In terms of overactive bladder symptoms following radiotherapy, there are only two papers. One was that fluvoxate, again, quite an old paper, showed improvement following pelvic radiotherapy. And then another paper in 2009 by Bittner et al. Showed that brachytherapy, detrusor overactivity-induced brachytherapy got better with trospium chloride. And there was one interesting paper that showed that taking cranberry tablets during treatment for prostate cancer actually lowered urinary tract symptoms following the treatment with radiotherapy. In terms of male incontinence and using the artificial urinary sphincter, it's unclear what the role of radiotherapy is. These are quite recent studies, and they showed that, in fact, radiotherapy made no difference to the outcome of the artificial urinary sphincter. So the first paper was a large number of patients, and the rates of incontinence or success were the same in the group that had radiotherapy compared to the group that had no radiotherapy. The second paper there, BJUI, 77 patients, again, no difference. And Ravia et al. Published last year, 160 patients, and showed no difference. They did show a slightly higher infection rate and explantation rate if you'd had radiotherapy. But the continence rates, revision rates, early complication erosion rates were all the same. However, Tim Terry published last year a meta-analysis looking at all papers, and in fact he showed a worse outcome following radiotherapy in patients who had an AUS, from 37% versus 20% in terms of revision or complication, and this was mostly from infection or erosion. And the number needed to treat was 4. So if you have 4 patients who've had radiotherapy and you put an implant in, one of those will need a revision. The success was lower in the irradiated group as well. And Simhan et al. Also last year published their series looking at the 3.5 centimeter cuff, and they also showed that erosion rates were higher following radiotherapy. In terms of evolving radiotherapy, so as I talked about earlier, in terms of radiotherapy is getting more and more focused, this study quite nicely looked at 2 groups from 2001 to 2006 and another group from 2007 to 2012. And in fact, the complication rates were the same in both groups, implying that even though radiotherapy is getting more focused, it really didn't make a difference to the outcome following artificial urinary sphincter. What about the male sling used for male incontinence? Well, there isn't much in the way of publication. Krishma et al. Published 41 patients and said that there was no difference with pre-op radiotherapy compared to no radiotherapy, but again had very low numbers of patients in the radiotherapy arm. And Zuckerman et al. Published, again, only 27 patients who had irradiation, but they all had equal success compared to those that had no radiotherapy, 70% claiming benefit from the male sling. Torrey et al. Published, again, radiotherapy outcomes following male sling, and his improvement rates, that says improvement, no change, or worse, were all much higher or worse in those that had had radiotherapy. So the EAU guidelines therefore made the statement that previous pelvic radiotherapy does not appear to affect the outcome of the artificial urinary sphincter, and they've given that grade 3, and they've recommended that we should warn men that severe incontinence prior pelvic radiotherapy or urethral stricture surgery may worsen the outcome of fixed male sling surgery, and not to offer any kind of proactive devices. In terms of female stress incontinence after pelvic floor training, often some people use injectable agents. This study looked at the use of Bulkamid in severe stress incontinence and looked at previous radiotherapy or no previous radiotherapy. And they found that complete continence was achieved in 25% who'd had previous radiotherapy and 36% of those without prior radiotherapy, implying that radiotherapy has a detrimental effect. In terms of artificial urinary sphincters in females, they also had a worse outcome following radiotherapy. But again, quite low numbers there. They're comparing 206 patients to 9 patients. And then looking at major surgery, again, very little in the literature about the outcomes of radiotherapy and the success of major surgery. And I can only find 2 papers. One was Sisen et al. that showed patients who had undergone a partial cystectomy and clam enterocystoplasty that their success was reasonably quite good, 72%. And in another paper by Chung et al., 49 patients with urinary dysfunction after uterine cervical cancer treatment. The radiotherapy group had earlier low urinary tract symptoms, smaller bladder capacity and poorer compliance, but they went on to have surgery such as a pubovaginal sling, Botox or bladder neck incision and a clam, and they claimed 90% success rates, but very poor quality research or in the literature really to make comment. In terms of radiation cystitis, I'll only briefly touch on these, but often these patients will have very bad bladders, very painful bladders, and why we see them often as an emergency is significant hematuria. And the things that the literature describes is alum irrigation, formalin irrigation, anticholinergic drugs, analgesic therapy or non-steroidal anti-inflammatory agents, and then quite commonly hyperbaric oxygen. And then there are some experimental treatments there. And I say experimental because the literature is poor on it, but Botox injection therapy, progenitor cell injection, and various other, and green light laser even, for the bladder. In terms of treatment specific for patients who've had radiotherapy and then developed low urinary tract symptoms, there are a handful of papers that are looking at this. There's 2 papers there that do show an improvement with installations into the bladder with hyaluronic acid and chondroitin sulfate. And then there's another paper looking at botulinum toxin injection for low urinary tract symptoms that showed an improvement, but again, only in 6 patients. So there are difficulties in giving this sort of talk and advising on which is the best management strategy, because all these papers and literature all have different definitions. We're used to treating patients for symptoms, whereas the oncologists are using GE toxicity. It's only more recently that we're focusing on patient-reported outcomes, and much of the early literature will have physician-reported outcomes. A further difficulty in making statements is that treatment modalities change all the time and are very frequently changing in the radiation oncology field. That the radiotherapy is trying to get more focus, and it's unclear whether this is getting better in terms of outcome for treatment. There are hardly any randomized controlled trials, and there's very little, and therefore, paucity in the guidelines in terms of recommending treatment. What seems to make sense and what we should be telling our patients is that radiotherapy seems to cause low urinary tract symptoms and incontinence, that treatment of this low urinary tract symptoms and incontinence can be very difficult, and therefore the patients should be counseled accordingly. And then the other things that we can do, and the public needs to be aware of, is tries to raise awareness that these symptoms do develop, and there is treatment at hand, and there are organizations such as the Radiation Cystitis Foundation. Thank you very much.
Thank you very much for that. We probably have got time for 1 or 2 questions if anyone's got anything they'd like to ask.
If you've got a question, please come to the microphone.
Hi. Why so little on ileal conduit? I mean, surely the important thing about these patients is, they've done badly, to kick it into touch, to set them back on the right road, to end the ruinous path of repeat useless treatments is an ileal conduit. And so deciding which people are eventually going to come to that after a miserable management plan is the key, and I don't know how to do that, but I mean that's what you want to be able to predict at the outset, I mean, a lot of these people, what you term success and failure and all these various options, they simply don't work, so you've got to decide who you're going to go nuclear on and who you're going to fanny around with.
No, that's a very good point. I think it's quite a lot, as you can imagine, for the patients to undertake. They've just overcome their cancer and their cancer treatment. But yes, talking to them about going straight for a conduit is quite a big step.
But it's good just to remind them, by the way, you knock on my door at any time, drop me in, we want a conduit, we'll do it.
Yeah. But really that's more of a discussion to have hopefully with the oncology follow-up, because these patients take a while sometimes to filter through. But I'd agree with you.
Thomas Lynch, Dublin. Urinary urge and urge incontinence is a big issue for some patients who have radiation cystitis, as is hemorrhagic cystitis. And I'd encourage you to incorporate hyperbaric oxygen as part of your treatment. You just mentioned as an aside, I think it's a very effective treatment. I've used it on a significant number of patients and I've had good outcomes. I've encouraged my colorectal colleagues to use it for proctitis, and they also have had very good outcomes, so I'd encourage you to use it.
Okay, well, that's interesting to know. I mean, there's no literature on it for urge incontinence. Lots and lots of literature for radiation cystitis. and hemorrhagic cystitis.
And of course, we need access to the chamber. We're quite lucky at Guy's because one of our oncologists, his friend, runs the local hyperbaric oxygen chamber, but of course the geography could be a potential issue.
Great, thank you very much, Mr. Thirachelvam. So I'm very pleased to welcome Professor Fisch to the stage to talk to us about her work on fistula repair.
So, good morning. I like to start my presentation with radiation-induced fistulas in females, and then I will switch over to males. And we just started the discussion about urinary diversion. So at the end of my presentation, I also will discuss with you the indication and the type of urinary diversion in an irradiated population. So the etiology, and this is a series here from the UK, in females for fistula is mainly surgery, and only about 10% of the fistulas in females are radiation-induced. Concerning the classification, the majority are vesicovaginal fistulas. So vesicouterine or urethrovaginal fistulas are rare. There is another classification. This is differentiating between simple fistulas, that means easy to repair, and you see that already complicated fistulas here, this is the irradiation group. So as soon as you have a patient who is irradiated, you have a complicated fistula. Other complicated fistulas are larger than 4 centimeters, affecting the urethra, ureter, cervix, or are recurrent. And of course, you can have complex fistulas like that where you have really a cloacae, and you see the damage here of the bone done by the irradiation. So this is another publication, and you see that the incidence of the radiation-induced fistula in this population was about 7%. Main indication for radiation was cervix cancer, and you see here the predictors to develop at least radiation-induced fistula. And the authors pointed out that you should avoid post-radiation biopsies because this is one of the major issues, and then you might get at least a fistula. Diagnosis, vaginal examination is very important. Then the vaginal packing and bladder installation with blue dye helps to see exactly where the fistula is, whether it is a urethra fistula or whether it's up higher. Avoiding cystogram is of importance, and you have seen a similar picture before. This is my finger in the vagina, and this is the huge fistula what is discovered during cystoscopy. And cystoscopy sometimes is difficult, so you could do a condom cystoscopy. That means put a condom over your cystoscope, and then you don't lose the fluid through the vagina, and this is a trick to get better view. Optionally, you also can do an IVU or MRI or CT. Timing of surgical repair, if it's a fistula repair, if it's a surgery-induced fistula, you either can do it within 72 hours or then do a delayed repair after 3 to 4 months. However, in irradiation-induced fistula, it's better to wait at least 6 to 12 months until the tissue is stable. Of course, a urinary diversion you can do at any time. Surgical approaches, and I like to point out again, quoting this paper here, that only about half of the irradiated fistulas in females will be closed. The others end directly into urinary diversion. So these are the techniques that had been described for repair, transvaginal repair, the Marcius flap. I don't think that this is suited, at least for radiation-induced fistula. The abdominal repair with using peritoneal flaps, or this is my preference, the omentum flap, and also the rectus abdominis muscle flap. So these here in red, that are the techniques that should be preferred for radiation-induced fistulas. In the majority of cases, you have at least to do a combined abdominal vaginal repair. And as I mentioned, the omentum flap, it's very good to interpose the tissue. So you can dissect from above, and you also can dissect from down. And you can bring it down, and in older patients, it's not even necessary to bring it in between the vagina and the bladder. You also could use it to close the vagina completely. However, this is only possible in older females that have no sexual intercourse anymore. This was a paper that described the abdominal repair using the rectus abdominis muscle flap. And there are not much data out, larger series, on fistula repair in this population. However, the good news is that in the overall publications, the success rate are very high, over 80%. As I mentioned, combined repairs, this is a favorite. There are some data out on laparoscopic and Da Vinci-assisted technique. However, these are just case reports. And of course, now the question of urinary diversion. So what type of urinary diversion? And as I mentioned, I would like to discuss it at the end of my presentation together with the males. So let's switch to fistulas in males. And you see on the top there is prostatectomy. But however, if you look closer to it, it's immediately followed by radiotherapy. And this is a study out of the year 2008. The incidence after radical prostatectomy is about 1%, and you see here the risk factors, and again, irradiation is a risk factor, and also salvage radical prostatectomy. After brachytherapy, if it's a monotherapy, the incidence is up to 5%, if it's a salvage, up to 9%. This is an overview, especially here. This is a very nice publication I will cite later on, overview of the literature. And you see that before 1997, less than 4% of the fistula in male were radiation induced, and we have a clear increase since. And today, 50% are radiation induced, and Heschen-Pleikner also said that already 2/3 nowadays are radiation induced. So we have a clear shift to more complex fistula also in a male group. So concerning the classification, we have the vesicorectal fistula. This is normally due to some bowel disease like sigma diverticulosis. The urethrorectal fistula, this is the main fistula after prostate cancer treatment, and of course the complex fistula. And what does it mean, complex fistula? And again, you see status post-brachytherapy, status post-anal beam radiation, or focal therapy if you have an additional urethral or anastomotic stricture, if you have a larger fistula, larger than 2 centimeters, and if you have a severe tissue damage, fibrosis, or what we now quite often see as a cavity in the area of the prostate, and of course, sphincter damage and small bladder capacity. So investigation, a cystogram is very important, especially the lateral view, so you exactly can see where your fistula is. Of course, cystoscopy and rectoscopy. And in the irradiated males, I always like to have an MRI because I like to know about this formation here, whether you have an extravasation, if you have a cavity. It's very important information in decision-making what to do with these patients. So these are the therapeutic options you have. You can either do a fistula closure. A couple of different approaches have been described. You can use an interpositioning of the gracilis muscle or the greater omentum. If the prostate is still in place, you could do a salvage prostatectomy, and at the very end, there is the urinary diversion. So these are at least the 2 things that should be done, irrespectively of the technique you use. You should interpose healthy tissue if you are dealing with a post-radiation fistula. So there are some advantages and disadvantages. If you use an abdominal approach, the fistula is deep in the pelvis, and of course it's dorsal, so you have to reopen your anastomosis. The advantage is you have an easy dissection of the greater omentum. If you do a fistula repair from a perineal approach, the advantage is you get an excellent exposition, and if you have an additional stricture, you just can extend your incision distally. The disadvantage is there is not much tissue there that you can use to cover, so you need at least the gracilis muscle in these cases. So going to the literature, and these are the data out of the last decade, you see all very small numbers. Majority used gracilis muscle, and you can see that the success rate is very high, reaching up to 100%. These are more recent data, also our own data are included, and again, not high numbers. Largest number is that from here, Vanni, who used also a muscle flap, but you see the overall success rate is very high. I like to go to that more into detail, and I like to show you this overview I already mentioned. It was a review, 26 articles included, 460 patients, and 40 of these had pelvic irradiation. So, and you see here the majority had a combination therapy. And that was the surgical approach. So the majority, especially the high volume centers, used the transperineal approach. The transanal approach mainly was used by rectal surgeons. So what was the tissue that mainly was interposed? It was in 72% the gracilis muscle. And again, you see the success rates are very high, reaching 90%. And there was no difference concerning the success rate, whether the patients were irradiated or not. But the functional result was completely different. And you see that in the overall group, permanent urinary diversion was needed in about 8%, a fecal diversion in 10%. But if you compare the two collectives, you see that the irradiated patients will remain on a urinary diversion in more than 40%, and on a fecal diversion in more than 25%. And one has to really question whether this collective would be better, as you mentioned, with a urinary diversion. So salvage prostatectomy, not really a lot of data out. The indication is when the prostate is not removed, when you have an additional stricture of the prostatic urethra. You should not have a larger cavity, and again, you have the two approaches you can use. As I said, no data out. If you look to the salvage prostatectomy data, and I just would like to focus on this review, you see that rectal injury is very high, so you again have a risk for fistula. You have a high rate of incontinence and a high rate of anastomotic stricture. So if you use something like that, it's really at high risk, and you have high complication rate. And as I mentioned, for the fistula repair, you have no data at all. Cystoprostatectomy and urinary diversion, if you have a severe fibrosis, tissue damage, if you have a large fistula with a cavity like that, if you have a small bladder capacity and urinary incontinence, the patient really is better with a urinary diversion. So how many of our patients will need it? And in our own series, about 10%, we have not closed the fistula, we just went to do a urinary diversion. However, 70% of the irradiated patients immediately went to urinary diversion. And these are other studies, and you see that the percentage of those patients getting a urinary diversion is anywhere in between 18 and 91%. So what type of urinary diversion? And I think we really have to have the information about the type of irradiation, the field, the doses, and also the time. And if this was really a pelvic irradiation, all the segments we normally use for urinary diversion are within the irradiation field. So you have the cecal region and you have the ileum in, and you should not forget you have the distal ureters. They also have an irradiation damage. So when you look to the literature, ileal conduit, pouch, and neobladder, this is a publication from Eisenberger in 2010. You see that all these patients had irradiation, and the overall complication rate was 77%. If you compare that with the normal population, you would expect a complication rate of around 30%, so half of it. Wilkins, Indiana pouch, 12 of those irradiated, and you see the difference. Non-irradiated, 57% of complications versus 83% of those who had irradiation. Tollhust, all irradiated, again, complication rate over 76%. And these were the old data out of my former institution in Mainz, where we had a reoperation rate of 70% in those patients who had irradiation versus 16% in those who had not. Nievenhusen, same figures, 44% early complication, 51% late complication. 1/3 of these patients had irradiation, and this is also another complication who compared at least the non-irradiated versus the irradiated group, and you see the difference, especially in the pouches. So irradiated patients have a higher complication rate of urinary diversion when standard segments are used, and the segments out of irradiation field may overcome these problems. And what are the segments that are outside of the irradiation field? It's the ascending, the transverse, and the descending colon. So you can use the transverse conduit even if you have short ureters. You can anastomose it directly to the pelvis. It's a little bit a complex technique, and it needs some bowel mobilization. And for the transverse pouch, we use a tailored segment which is incorporated in the anterior wall as a urinary diversion. So what is the literature saying on it? And this is a quite old publication from a gynecology population. You see all these had a cervix carcinoma, all had irradiation, heavy irradiation, and you see the complication rate is quite good. Transverse pouch, here included our own data, and we have now, at least a follow-up of almost 5 years, and you see continence rate are excellent, and also the complication rate are comparable to patients with a normal ileocecal segment without irradiation. So I'd like to summarize, in females, about 10% of the fistulas nowadays are radiation induced, and the main indication for the radiation is cervix cancer. We deal in 74% with the vesicovaginal fistula. The best approach is a combined transabdominal vaginal approach, but you should interpose either omentum or abdominis muscle flap. However, only about 50% are suitable for a repair, so the others will need a urinary diversion. Fistulas in male, today 2/3 are radiation induced. Mainly the perineal approach, at least at high volume centers, is used, interposing the gracilis muscle. The overall success rate is very high with 90%, but at least the irradiated patients have higher complication rate. So they need, in a quite high number, a permanent urinary diversion or a fecal diversion. And as I already discussed, maybe these patients really are better with a high urinary diversion. So thank you for your attention.
Thank you very much for that. Again, we've probably got time for one question. Is there anyone who has anything they'd like to ask?
Okay, I'll have one quick question. So, of course, the problem, I think, in the gynecology arena is that a lot of these patients are young. And so you have to make some very difficult decisions, don't you, I think? Because if you've got a young woman in front of you, 28, 29 years old, has had brachytherapy, radiotherapy, devastated pelvis, you know, you may have to, I mean, the decision-making is important the first time, and you may have to commit to a diversion even in young people, is that right?
Yeah, and I think with the pouch, with the continent diversion, you have a good option even for these very young patients. And these are the patients we normally offer a transverse pouch.
One other technical thing is, I agree, transverse colon outside the irradiation field is sensible. A lot of people are still using ileum. They just find a bit of ileum which they hope is not irradiated or doesn't appear irradiated.
So if you like to do a conduit, I really would prefer to use the transverse colon because it's flexible. It has a mesentery which is long, so it's very easy to handle. And as you have seen in the literature, I mean, the ileal conduit per se has a high complication rate, but in irradiated patient, it's even higher. So I really would recommend to take the transverse segment colon as a segment for a conduit.
Thank you very much.
Lastly, I'm very pleased to welcome Tasha Malinowski from Prostate Cancer UK to talk to us on survivorship.
Thanks for having me here today. I'm just going to talk about our Health and Social Care's Professionals Program, and that we've funded projects which look at innovative models of care to support men living with and beyond prostate cancer. Prostate cancer is the most common cancer in men in the UK. 80% of men are expected to survive for more than 10 years, and currently over 300,000 men are predicted to be living with and beyond prostate cancer. Are we doing enough to support this group of men? There's evidence acknowledging that current care delivery is not providing a person-centred follow-up to men with prostate cancer, and there is a need to redesign prostate cancer care pathways so that post-treatment care is tailored towards the individual. Some of the unmet needs that men are reported include information needs, ongoing neurological symptoms, psychological symptoms, and sexual needs. The Health and Social Care Professionals Program was established by Prostate Cancer in 2012. Jointly funded by Royal Mail in Movember, it aims to test new models of care which improve patient-centred care and follow-up support. We have funded 59 professionals across 45 projects. This is a picture from our networking day last year showing the team of professionals. We funded mostly nursing roles, but have also funded physiotherapists and a radiotherapist role. The roles work closely with the whole clinical team, and the most successful projects have had support and engagement from across the MDT. This chart shows the number of people who have been supported to date, with over 34,000 people. I'm just going to talk a little bit about the program findings today. Over 6,000 men have reported satisfaction with the support or care they've received from the program, and 3,000 men have been supported to self-manage their condition and feel more informed about treatment. Reasons for positive experience of care include opportunities to attend support groups and education seminars, access to CNS and specialist physiotherapists, and feeling emotionally supported by their CNS. Across the program, we have seen improvement in outcomes which range from clinical to service and have an impact on the care of the men. These include improvements in lower urinary tract symptoms, quality of life, and physical activity. Men also have reported feeling more in control of their physical side effects. The program has also supported improvements to referral processes and reduced waiting times. Just going to run through 4 case studies of some of the projects that we've funded. The projects have focused on supporting men across the treatment pathway and the management of functional side effects. And one of the case studies that I'm going to talk about focuses on men who have undergone radiotherapy treatment. Just to start with, at Guy's and St Thomas, they introduced a new pathway with a survivorship focus. This was focused on all treatments and was based on findings from patient and professional focus groups. This was run by Paula Alcom, the CNS at Guy's. The new pathway introduced pre-treatment sessions, post-robotic surgery seminar sessions, post-treatment seminar sessions, and a discharge seminar. Results showing the impact of the new pathway included 99% of patients feeling more supported and confident, 100% of men felt more confident in coping and understanding the discharge process, and 100% reduction in urethral strandology incontinence over a 6-month period, which helped to reduce bottlenecks. The new pathway has helped to streamline patients to appropriate clinics, and an extra 250 ED incontinence patients can be seen a year without any extra resource. Just going to talk, this is a quote from one of the patients who attended the seminars. I was too embarrassed to ask questions myself, but I was able to listen to other men and learnt so much. Just going to talk about a program at Newcastle-on-Tyne Hospital, which was run by a CNS, Jill Ferguson. This introduced a NEST prostate cancer survivorship program tailored to address men's health and supportive care needs. The graph outlines the service that was introduced. Men can access support in face-to-face appointments, education events or courses, and also in dedicated functional units. Holistic needs assessments were a key part of the program. This new pathway has shown an improvement in patients' perceived quality of life, and also distress scores have been halved. This is a couple of quotes from some of the men who have attended some of the courses. I knew I needed help, but wasn't sure where to get it from. Best thing I've done, met some great people, and I can get back to my life now. The project that we funded at the Christie focused on men undergoing radiotherapy, and it was involved a set of a review clinic where men were seen weekly for a 6-week period. The clinic was education focused to help patients with the side effects of the treatment and how they can manage. Each patient received a personalised summary at the end of the treatment, so they understood treatments and they have had, and also the potential side effects. Patients surveyed felt they had better access to care and support with the addition of the clinic, and there's also been a national audit which is waiting a publication looking at current practice in prostate cancer radiotherapy reviews. Patients commented that seeing the same person in clinic each week helped with the continuity of care. Finally, going to talk about a project which was jointly run by BAUS and St Joseph Hospice. It was a physiotherapist-led project which was a rehabilitation service which was tailored to meet the needs of prostate patients through the disease pathway. It involved health and wellbeing clinics and also individual physiotherapy sessions. The impact of this intervention was quite strong. There was a 209% increase in physical activity among the men that attended the clinics, 59% improvement in lower urinary tract symptoms from moderate to mild, and 17% decrease in urinary incontinence. And I'm just going to show a video which runs through the service and the professionals who run it. Just check that it all works. Oh, sorry, this is just a quote from some of the patients, and hopefully this will all work.
So the programme we're running is with Barts Health and St Joseph's Hospice, and it's to improve rehabilitation for men with prostate cancer in North East London. I think the bottom line is that exercise and exercising regularly to a moderate intensity, there's a good body of evidence to show that it reduces progression of prostate cancer, recurrence and mortality. And I think that's the cornerstone of getting that into the pathway and into the clinics and to all the men. The key components are seeing men for one-to-one educational sessions, and then those that are symptomatic of fatigue, continence issues, lymphedema, or having trouble with mobility will then be seen by myself for 4 to 6 sessions, and ideally, if need to be, signposted to current services after that. And then an exercise group as well. So it's to try and put in place pathways that are sustainable for exercise in prostate cancer.
I mean, for us as a service, one of the very important challenges is going to be sustaining this, absolutely, because I don't think we want to lose the momentum that we've got now. The patients have spoken about this service really, really highly. We've started to do a lot of things on the back of this in terms of improving the health and well-being of our patients. So I think with the commissioners, as much as possible, we have to get feedback from our patients to show that this works. We have to have concrete evidence that this works, that we can show the commissioners to say this is not just something that we like, but this is something that's essential, and it's also providing value for money.
We used to sort of measure incontinence at a year after surgery, and now our goal in actual fact is to have every man continent if we can within 6 weeks of surgery. So Helen's efforts help us achieve this, and it's very important. There's a very big difference walking around wetting yourself for 6 weeks as compared to a year or more. And we've been aware of this need for a long, long time, so Helen's presence has solved a big problem for us.
It's been absolutely fantastic. I've been really surprised and blown away by it, really. It's been brilliant for our team and for our service. We've not had anything like this before, to have a person who's a resource, who's in clinic with us, who spends time with the patients in the way that perhaps the doctors and the clinical nurse specialists don't have, to talk through all these very important issues around their general health after treatment, their urinary symptoms, their issues around fatigue, diet, exercise, all those kind of things. It's been really, really positive for the service.
It means a lot to me. It gives me a way forward. It means that, yes, the condition I have now is not going to be forever. There is going to be a change. And there is a continuous encouragement, you know, and to me that means, you know, if you know where you are going, then you have a hope that one day I'll get there. And that's what I'm looking forward to. Yes.
Yeah, Helen been helping me good. I get the best treatment that I can get, and all the doctors and very, very helpful, and they talk to me about it. And you get booklets and leaflets that telling you all about the prostate. Since the operation, it's been a lot better. I can do things that I couldn't do before because I was so tired before, but now it's better.
That's actually been funded long term now, so there's a physiotherapist working with the men at BAUS now, so that's great news. Was that finished? Oh, sorry.
So the programme we're running
Sorry, not
is
sure how to stop it. Okay, sorry, every time I click it seems to start again. So Prostate Cancer UK, we use the results from the programme and the case studies to better support men with prostate cancer and to ensure that everyone knows what the best standard of care is and that men across the UK have access to it. We'll be developing a best practice pathway which will set out the best available treatment, care and support for men throughout the cancer journey, and it will form a basis for tackling variation in treatment across the UK. On our website we have case studies from the other projects that are involved in the programme, and there's also a link available. We've also, at our stand, there's a programme summary booklet as well, which has a summary of all the projects.